Good evening. Hello, and welcome to our program titled Evolving Strategies for the Management of Hereditary Angioedema, a patient-centered approach with real-world examples. I am Maeve O'Connor, a practicing allergist and immunologist in Charlotte, North Carolina, and my disclosures are listed below. Dr. Talreja?
Hello, thanks for having me, Dr. O'Connor and the Integrity team. I'm Neetu Talreja, and I'm a practicing allergist at the Allergy Group in Boise, Idaho, and you guys can see my disclosures as well.
Thank you very much. So tonight, we'll be exploring the evolving landscape in the management of hereditary angioedema, or HAE, with a particular focus on patient-centered strategies and real-world clinical applications. Our learning objectives for tonight are to apply guideline-recommended strategies to accurately identify patients with HAE, analyze and compare approved and emerging treatment options for managing HAE effectively, and to utilize shared decision-making and validated assessment tools in the development of treatment plans for HAE. First, we're going to introduce hereditary angioedema. So HAE is a rare and potentially life-threatening disorder. It's characterized by unpredictable episodes of swelling. These swelling attacks can affect the skin, the GI tract, as well as the upper airway. Timely recognition and appropriate management are essential to improving patient outcomes. So the clinical features of HAE, it often presents with those recurrent episodes of swelling. The swelling is non-pruritic, non-pitting. There's no urticaria or itching, and this is very important to differentiate HAE from allergic angioedema. The attacks may involve the extremities, the face, the abdomen, or the airway. And again, unlike histamine-mediated angioedema, HAE does not respond to antihistamines or steroids. Now, HAE is typically an autosomal dominant disorder. We have HAE type 1 or HAE type 2, which are characterized by C1 inhibitor deficiency or dysfunction, respectively. HAE with normal C1 inhibitor, also known as HAE normal C1, these patients have normal levels as well as normal function of C1 inhibitor, but they present almost identically to HAE type 1 and type 2. So acute attacks can have variable onset. The majority of them will develop gradually over hours, but there are reports of acute attacks as well, which also makes it difficult sometimes to distinguish from allergic angioedema. The attacks of HAE can be prolonged. They usually increase in intensity over 24 hours, and it takes about 2 to 4 days for complete resolution. Again, unresponsive to the medications that can treat allergic angioedema, antihistamine, steroids, even epinephrine. And again, the acute attacks are unpredictable with varying frequency as well as variable triggers. Common affected areas, again, face, extremities, and genitals, oropharynx, as well as the GI tract. And the first symptoms can appear in childhood or adolescence, but not always. And this can also lead to some of the delay of diagnosis that we see in these patients with hereditary angioedema. And common triggers, again, vary from patient to patient, but can include trauma, whether it's a minor injury, a bump or a bruise, or something more invasive such as surgery or a dental procedure, emotional stress, and estrogens, oral contraceptions, and pregnancy as well. So it's important to recognize and minimize known triggers in patients with HAE. So this is a schematic that illustrates the underlying pathophysiology of HAE. So we have the complement pathway and the contact activation pathway. I think we all remember memorizing this in medical school. I certainly do. But in the classical complement pathway, the complement protease C1 is activated and then assembles the C3 convertase. And you can see that the activation is indicated there by horizontal bars over the complement names. And then in the contact activation pathway, trace amounts of factor 12A activate additional factor 12, as well as activating prekallikrein. The activated factor 12A then activates factor 11 to factor 11A, and that leads to enhanced fibrin formation. And the activated factor 12A and kallikrein activate one another. And then the plasma kallikrein cleaves high molecular weight kininogen to release bradykinin. And the central defect in HAE is a deficiency or dysfunction of C1 esterase inhibitor, thereby leading to uncontrolled activation of this contact system and increased bradykinin, which of course is a potent vasodilator and is responsible for the swelling episodes that I discussed in the previous slides. Now, it's important to distinguish mast cell versus bradykinin-mediated angioedema, not only for proper diagnosis, but also to help us determine the best treatment plans for these patients. With mast cell-mediated angioedema, typically an allergen or a medication, even an autoimmune trigger, will activate the mast cell, which then degranulates and releases histamine and other pro-inflammatory mediators, and that leads to allergic angioedema. We just reviewed how hereditary angioedema occurs, but again, you can see the differences here. Again, HAE not responding to traditional allergy medication as it is bradykinin mediated, and recognizing this distinction is important to prevent treatment delays as well as unnecessary interventions. And again, the delay to diagnosis for hereditary angioedema can often be because of not making this distinction. So I mentioned different types of HAE, and this is looking at the classification system. And you can see C1 inhibitor deficiency and then normal HAE with normal C1 inhibitor. And when we think about type 1 and type 2 HAE, it's usually due to the SERPINE1 mutation. It gets a little more complicated when we talk about normal C1 patients, HAE with normal C1. The factor 12 mutation has been well described in the literature, and there are other mutations listed here, including plasminogen, angiopoietin-1, kininogen, etc. And then there are patients who still have unknown genetic defects that present and are diagnosed as HAE with normal C1. So it is important to know that this is also an evolving part of HAE, the diagnostics and identifying the genetic mutation, as well as the evolving landscape for treatment, which we're going to go into a little bit more detail in a moment. But first, we're going to talk about the diagnosis of hereditary angioedema. So when to suspect HAE? We know that this disease causes recurrent swelling of the skin, again, extremities, face, genitals, and the GI tract can cause those severe abdominal attacks. Patients can report mild cramping all the way to patients developing such severe pain that they may even get exploratory surgery to evaluate the cause of that. Also, the laryngeal edema is something to look out for. Obviously, that can be life-threatening. So additional clues other than the swelling can include family history. Although it is autosomal dominant, this is absent in about 25%, but certainly if a patient reports a family history with swelling, HAE should come to mind. Onset of swelling episodes in childhood or adolescence, painful recurrent abdominal symptoms that are unexplained, upper airway edema, and then again, that hallmark of not responding to antihistamines, steroids, epinephrine, or even omalizumab. Prodrome symptoms can occur in some patients before swelling episodes. Patients may report a rash or just a funny feeling, perhaps a headache. And again, this angioedema is heralded by the absence of urticaria, no wheals. So any of these red flags should prompt further evaluation. And again, keeping in mind that family history may be absent in about 25% of patients who actually do have HAE. So here is an algorithm for the diagnostic workup in patients with suspected hereditary angioedema. So you do have to have a high index of clinical suspicion, thinking about the clues and the red flags that we just reviewed, and also, of course, just listening to our patients and perhaps some of that family history. So then a C4 level would be ordered, and that's done either by radial immunodiffusion or turbidimetry. C1 inhibitor level, C1 inhibitor function, and how those are performed is there as well. And if these are reduced, any of them or all of them, we then would recommend repeating the blood test to confirm the diagnosis. If you have a normal C4, normal C1 inhibitor level or function, then that is when you may proceed to genetic testing, especially thinking about those mutations associated with HAE with normal C1 to see if we can get a diagnosis of that. So this is an algorithm that can be helpful in those patients where you suspect HAE. Now, this table shows laboratory profiles for patients with type 1 and type 2 HAE. So both will usually have low C4 levels. And then type 1 HAE will show reduced C1 inhibitor level and function, while type 2 may display normal or elevated C1 inhibitor levels with reduced function. So that elevated C1 inhibitor would be more indicative of the type 2, and that can help lead to the proper diagnosis. So again, these patterns help differentiate between the types, and again, then can help guide therapy selection with our patients. Of course, also exercising shared decision-making, which we will get into as well. So genetic testing is primarily used for confirming HAE with normal C1, like I mentioned earlier, or if you have a case of a patient who may have inconclusive labs. It should not be done as a frontline test because of the availability of the test. And also, we want to be good stewards for genetic testing, considering cost-effective biochemical tests as first line. Again, if thinking about HAE type 1 or type 2 and ruling those out before going on to genetic testing. False negatives for previously unidentified variants of SERPINE1 are also possible, so that is a consideration. But genetic testing is very helpful because it may detect the SERPINE1 or factor 12 gene variants in patients with normal C1 inhibitor levels. And as we have more evolving treatments for hereditary angioedema and insurance companies may require genetic testing, this may be something that changes in the future, but now we still want to be good stewards for genetic testing. So the key recommendations from the WAO-EAACI hereditary angioedema guidelines strongly recommending screening family members of patients with hereditary angioedema. And this recommendation is with 100% agreement with an evidence level D. So why is testing important? Again, delayed diagnosis is rampant, and it can increase patient morbidity, decrease their quality of life, and delay appropriate therapy, which now we have readily available multiple options. The other reason why genetic testing is important is because the first HAE attack can affect the airways or abdomen and can cause life-threatening symptoms or even the unnecessary surgery, as I mentioned. So if a patient was prepared with on-demand therapy, even if they had not had an attack but knew their genetic testing was positive, this could prevent some of that. So who should be screened? And I would say everyone, but certainly grandparents, parents, siblings, children, and grandchildren. The tests that would be used would be the ones I've already reviewed, the C4, C1 inhibitor level and function. And then when diagnosed, on-demand therapy should be prescribed immediately and available again for the first and future attacks, even if no attacks have occurred yet. Oftentimes patients will ask about this, well, why am I getting it? I haven't had an attack yet, but it's very important to avoid asphyxia or unnecessary surgery, as well as cost of an unnecessary emergency visit. What about the burden of HAE? This is very high for patients with HAE, as well as caregivers involved in patients with HAE's lives. So when we think about the total disease burden, we know, of course, that acute attacks are going to cause a lot of burden for these patients. But really, the burden of HAE extends well beyond acute attacks. When we think about the burden of attack, where the attack occurs, how severe are the symptoms, how long are the symptoms going to last? Again, I mentioned resolving 2 to 4 days. If a patient requires an emergency visit or a hospitalization, the disruption of life that's caused by the attack itself, not only maybe missing work or school, but also disruption in social activities, the normal routine that a patient may have being interrupted due to an acute attack. But really, I think what's under recognized and really not discussed as often as I think it should be with patients is that burden between attacks. Patients live in fear of their next attack and how severe the next attack is going to be. There's a lot of studies that show increased anxiety and depression in patients with chronic illnesses, including those with HAE. And then the interference, and again, I mentioned career and education. These patients, if they're missing a lot, may not advance as they normally would if they were attack-free. And then the lifestyle modifications that patients have to employ to avoid triggers. I don't know about you, it's pretty difficult to avoid stress, and that being one of the most common triggers, that can be very difficult. So the disease burden of HAE cannot be overemphasized. And when we think about the caregiver burden in HAE, the caregivers often will suffer from just as much, if not more, burden than the patients themselves. And this can affect the support of the patient and lead to a vicious cycle. Caregivers often take on the responsibility of monitoring symptoms, managing medications, and handling emergency situation. You can see that on the left-hand side of the slide. This was published in 2021, looking at the HAE-related tasks that are performed by caregivers, everything from making treatment decisions to travel decisions to administering medications to the household duties. So a lot of burden is seen in the caregivers. And then when we think about the impact of HAE treatment on caregivers, these caregivers were polled and asked the questions that are listed there. I don't need to schedule personal and professional obligations around helping my patient take their medication. 53% agreed with that, but 26% disagreed and thought that they did need to make changes in their schedules. The injection infusion is unpleasant. 34% disagree with that, but look at the percent of those that did, 65%. So you can see that not only are there a lot of HAE-related tasks performed by caregivers that contribute to the caregiver burden, but also the impact of HAE treatment on the caregivers is also listed here as surveyed caregivers answered themselves. What about assessing disease control? So we have physician-reported outcome validated tests for multiple diseases that we treat, including asthma and allergic rhinitis. We also have the angioedema control test, or ACT. And these questions that the patients answer are listed here. In the last 4 weeks, so it looks at retrospectively at the last month, how often have you had angioedema? How much has your quality of life been affected by angioedema? How much has the unpredictability of your angioedema bothered you? And how well has your angioedema been controlled by your therapy? So I like this control test because it not only talks objectively, but it also looks at quality of life and those the burden of the attacks and what happens in between the attacks. So the interpretation of the angioedema control test is a total score of less than 10 points indicates poorly controlled disease, because you look at the scale, not at all being 0 and very well being 4. Anything less than 10 can indicate poorly controlled disease. My patients like this because it gives them something they can kind of hang on to and understand their disease over time. And perhaps when we need to have a discussion about their current therapy and making a change, or if something in their life is triggering them that they may need to avoid. So trigger avoidance for improving quality of life in hereditary angioedema is very important because it can help reduce attack frequency and give patients some of their quality of life back. Again, managing stress, I always kind of laugh at that one because it can be very difficult, but there are things that patients can do, including meditation and yoga, and getting support, psychological help, going to therapy to help with the anxiety or depression that may go along with this, controlling infections, trauma, and certain medical procedures using the situational medication that we're going to discuss. And this is very important when we think about trigger avoidance, because again, the patient is at the center of this, trying to avoid the acute attack, but caregiver involvement is very important here, as is the medical team. So not only the allergist immunologist who's managing the HAE patient, but also the primary care physician and others who may be involved, so that the patient can avoid triggers as much as possible and have the best quality of life possible despite living with HAE. So what about the treatment of HAE? I can tell you it's been an exciting time being a provider taking care of HAE. I can remember writing my first prescription in 2008 for the first FDA-approved medication, and it has continued to be exciting for patients as more treatments have become available. And the general treatment strategy for HAE is really three-pronged. We have on-demand therapy, we have short-term prophylaxis, and we have long-term prophylaxis. So on-demand therapy, of course, rapidly stopping attacks at the onset before morbidity and mortality can occur. And on-demand therapy is required for all patients, and there needs to be enough on hand to treat 2 or more attacks at all times. Short-term prophylaxis, preventing attacks for those at increased risk with known triggers. So again, I mentioned dental procedures or medical procedures, or even if a known stressor is coming in the future, such as a wedding or a presentation, for example. This is also referred to as situational prophylaxis. And then long-term prophylaxis, and this reduces the disease burden by decreasing attack frequency and severity. This is individualized. This is another area where shared decision-making is very important because this is something that is taken on a regular basis. And again, treatment must be individualized to provide optimal care and normalized quality of life. None of these patients are identical to each other, and they may have different desires and different facets of their disease where one treatment may be more suited to them than another. The key recommendations for treatment, according to the HAEA Medical Advisory Board, these are the 2020 guidelines for the management of hereditary angioedema. And this is, again, reiterating that ensuring all patients have access to on-demand therapy, treating all attacks, regardless of site or severity, and self-administration is preferred. Providing prophylaxis, again, short-term, having this before known triggers, procedure, stress, as I mentioned, long-term prophylaxis, individualized using C1 inhibitor or lanadelumab, and considering progestins and antifibrinolytics for HAE normal, but there's limited evidence on this, and patients with HAE with normal C1 often respond to medications that are FDA approved for type 1 and type 2. But it is important to individualize and regularly adjust management plans. Again, that's where that physician-reported outcome, the AACT really can be helpful. Prioritizing quality of life, adjusting first-line therapies based on age, and then avoiding exogenous estrogens. Preferred use of C1 inhibitor during pregnancy and breastfeeding. But again, the choice of agent and route of administration should be highly personalized. We want to really reduce the burden of the disease, not only on the patient, but also on their caregiver, so that we can optimize their quality of life. So this is what I was alluding to about the exciting treatment landscape that's currently available for our patients with hereditary angioedema. This timeline shows the evolution of FDA-approved treatments, starting with, of course, the IV plasma-derived C1 inhibitor in 2008. That's the one I remember writing on a paper prescription pad. And now, as we all know, the treatment landscape has progressed. We now have subcutaneous, recombinant, monoclonal antibody, as well as oral therapies. And the development of novel therapies has really expanded patient choice, and it's enabled more individualized, tailored, and less burdensome treatment plans. And really the evolution continues, which we're going to review in a few moments. But first, I want to talk about on-demand therapies for HAE. Acute HAE attacks, again, requiring prompt, on-demand treatment, reducing morbidity and the risk of asphyxiation. The available on-demand treatments are shown here, and they do target different points in the bradykinin pathway. So icatibant blocking the bradykinin B2 receptor, thereby preventing bradykinin from causing that vascular leakage that leads to the swelling. Ecallantide, that inhibits plasma kallikrein, reducing bradykinin production. And of course, C1 inhibitor replacement, whether it's recombinant or human, restores deficient or dysfunctional C1 inhibitor, and that gets to the root cause of excessive kallikrein activation. So now let's look quickly at some of the data that got these medications FDA approved for treatment in our HAE patients. So when we think about C1 inhibitor replacement for on-demand treatment of HAE, this was published in 2009, and it was one of the first studies to evaluate on-demand treatment of hereditary angioedema. And as you can see, the results demonstrated that symptom relief was achieved significantly faster with C1 inhibitor versus placebo. And this also had a favorable safety profile. There were no seroconversions or transmission of blood-borne viruses, which was a big concern in HAE patients when this first came to be available. This also reinforces what we all know, that C1 inhibitor remains trusted and the widely used option for on-demand treatment for patients, and not only those who are pregnant or breastfeeding. This is looking at edema 3. This was the study, the landmark study looking at on-demand treatment of HAE with acalentine, again, the plasma kallikrein inhibitor. And you can see here the results showing that acalentide effectively reduced symptom severity compared to placebo. And the key endpoints here were the TOS, which is the treatment outcome score, and the MSCS, which is the mean symptom complex severity. And both of those scores were significantly better in the acalentide-treated patients versus placebo. I think it's important to note that there are no deaths or treatment-related serious adverse events that occurred in this trial, supporting its safety in clinical use. And certainly, we have a lot of experience with patients on this now. So what about icatibant? Again, icatibant being the bradykinin B2 receptor antagonist. This was the FAST-3 trial. Lumry and Associates published this in 2011. And you can see that the median time to onset of symptom relief was faster with icatibant compared to placebo in non-laryngeal HAE attacks. The injection site reactions were common, as you would expect with an injection, but they were mild and self-limiting. And again, icatibant is a little bit different in that it is self-administered. So it is a subcutaneous self-administered option, which can be beneficial for patients wanting independence, as opposed to acalentide, which requires a healthcare provider for administration. Now, switching gears, we're going to talk about prophylactic therapies for HAE. This again is looking at a nice schematic, looking at the mechanism of action. Again, we've had therapeutic advancements in this, and it's allowed patients to have reduction in their attack frequency and severity. And here we remember we had C1 inhibitor replacement therapy, restoring those baseline inhibitor levels, the lanadelumab monoclonal antibody inhibiting plasma kallikrein, and berotralstat, the first oral kallikrein inhibitor for prophylaxis. So again, this is expanding patients' options. So we can really look at patient preference as well as their frequency of attacks, the severity of attacks, and preferred route of administration. When we look at the trials for HAE prophylaxis, this was the COMPACT trial looking at prophylaxis with subcutaneous C1 inhibitor. And you can see here the percentage of patients having significant reduction in their attack frequency was much higher with subcutaneous C1 inhibitor versus placebo. And again, AEs were mild and mostly consisting of local site reactions, again, not unexpected with the subcutaneous medication, but again, convenient subcutaneous administration and patient preference here, having another option for patients. Now, this was the HELP trial published in 2018, looking at lanadelumab for HAE prophylaxis. Again, the monoclonal antibody against kallikrein. And you can see the findings here showing the substantial reductions in HAE attack rates with lanadelumab compared. And you again can see injection site reactions and dizziness were more frequent with lanadelumab, but were manageable and considered mild. So lanadelumab is unique because it's offering a targeted biologic option, and the infrequent dosing is preferable for some patients. Again, you would have shared decision-making discussion. The APEX-2 trial was the landmark study published in 2021 that helped oral berotralstat get FDA approval for HAE prophylaxis. This is looking at efficacy of daily oral medication for preventing HAE attacks. And you can see here the significant improvement with oral berotralstat at both doses compared to placebo. And the most common AEs were abdominal pain, vomiting, diarrhea, and back pain. Important that there were no drug-related serious TEAEs which occurred. And I think it's important to emphasize here the oral prophylactic option for patients who may have needle phobia and may prefer to avoid injections. The Vanguard trial looked at garadacimab, a monoclonal antibody targeting factor XIIa. Of course, we know that that's that upstream trigger we saw in the cartoon earlier in the bradykinin cascade. So this is, again, another novel mechanism of action like lanadelumab. The key findings from this We're looking at the monthly attacks during the 6-month treatment period and reduction in HAE attack rate per month. And you can see fewer monthly attacks over the 6-month study period. And again, there was good tolerability. Most common TEAEs were upper respiratory tract infection, nasopharyngitis, and headache. And factor XIIa inhibition was not associated with an increased risk of bleeding or thromboembolic events, which was a major concern, and why I reviewed the pathways that are intertwined there, but no increased risk of bleeding or thromboembolic events were seen in the Vanguard trial. So I mentioned how exciting it has been since 2008, and it continues as we have several investigational therapies for hereditary angioedema that are on the horizon. This table outlines this nicely, looking at sebetralstat, which is an oral plasma kallikrein inhibitor being looked at in the phase 3 confident trial. This is for acute treatment. The NDA is submitted. The PDUFA date was scheduled for June. It has been delayed, but not due to safety reasons. And this would be the first oral on-demand therapy if it is approved. Then we have donidalorsen, which is an antisense oligonucleotide reducing prekallikrein expression. The OASIS HAE is the phase 3 trial looking at this for long-term prophylaxis. Positive phase 3 so far, and the NDA is expected in 2025. Now, gucrictibant is recruiting for their phase 3 trials. This is the oral bradykinin B2 receptor antagonist. We have the acute as well as long-term prophylaxis studies that, again, are currently recruiting. And if this were approved, it would be the first for both, other than C1 inhibitor itself. Then we have NTLA 2002, which is the in vivo CRISPR gene editing of kallikrein B1. Enrollment is complete for H2 2025, a potential BLA in H2 2026, and potential launch in 2027. The HALO is the name of the phase 3 trial for this, looking at long-term prophylaxis with one-time gene editing. So this is a very exciting time for HAE since 2008, and we keep having more. So when we look at this evolving treatment landscape for HAE, keeping in mind that we already have the human and recombinant C1 inhibitor for both on-demand and prophylaxis, berotralstat, first oral prophy agent, ecallantide and icatibant for on-demand use, and lanadelumab, the monoclonal antibody used for long-term prophylaxis, we know that treatment has shifted focus, and we don't only want to look at on-demand care, but also that proactive management and improving quality of life. And you can see that here, we can see this overlapping with our new medications that are on the landscape and coming, including the donidalorsen, the sebetralstat, and you can see all of that there. So looking at some of the data for our evolving medications for HAE, we have the CONFIDENT trial, which I mentioned, looking at sebetralstat for on-demand treatment of HAE. Again, oral plasma kallikrein inhibitor for acute attacks. And you can see here that the study showed faster onset of symptom relief, significant reduction in attack severity, rapid complete resolution of attacks, and again, a favorable safety profile. No SAEs related to the trial agents have been reported. And again, if this is approved, it will become the first oral option for treating HAE attacks. Looking at OASIS HAE, looking at donidalorsen efficacy in hereditary angioedema. Again, this is the antisense oligonucleotide targeting the kallikrein mRNA. You can see the key findings here: substantial reduction in attack rate. A high percentage of patients experienced reduced frequency of attacks. And again, a favorable safety profile. Most of the AEs were injection site reactions, headache, nasopharyngitis, and 98% were mild or moderate in severity. Donidalorsen is administered subcutaneously and again may be well suited for patients due to less frequent dosing. As you can see here, it's studied at every 4 and every 8-week administration. Chapter 1 is the gucrictibant for prevention of HAE attacks. This is phase 2 data that I'm showing here, looking at overall monthly attack rate, moderate and severe attacks, as well as on-demand treated attacks. And you can see here that the deucrictibant is successful at both 20 and 40 milligrams across these three outcome measures compared to placebo. And again, all TAEAs were mild in severity, no serious, severe, or TEAs leading to treatment discontinuation occurred. So this is very promising early results. The development of this is ongoing. And then we have the CRISPR-Cas9 in vivo gene editing here. So this was a phase 1 study. A single dose of NTLA 2002 led to robust, dose-dependent, and durable reductions in total plasma kallikrein. Again, no SAEs have been observed. In exploratory analysis, reduction in number of angioedema attacks per month were observed at all dose levels, with the primary outcome being the change from baseline in the number of angio attacks per month. So I know that patients are excited about all of these options that are on the evolving landscape for treatment of HAE. So now that we've reviewed the science very quickly in the interest of time, the practical recommendations for improving HAE management are going to be reviewed next. And it's really summarizing everything that we've already discussed, individualizing treatment plans. And this would be based not only on attack frequency and severity, but also patient preference, providing all patients with access to effective on-demand treatment for acute attacks and having enough on board for 2 or more acute attacks, considering long-term prophylaxis for patients with frequent or severe attacks, and then recommending short-term prophylaxis before procedures that have been known to trigger attacks, including stress. And encouraging self-administration because this can reduce treatment delays and also improve quality of life for patients who have HAE. So shared decision-making, I know I've mentioned it a lot. It's very important to drive best patient outcomes. And really the 3D model is best used for HAE management: discuss, discover, and decide. So discussing the alternatives. Again, we just reviewed, there are a lot of them and more coming. And, you know, the broad overview that we did tonight, I think is probably more than patients need, but some patients really do want the level of detail that we went into tonight. So going into whatever detail your patient wants, ensuring alignment with goals, and then developing informed preferences. We really need to dive into what patients want. Are they needle phobic? Do they prefer an oral medication? Are there other concerns that need to be addressed in looking again at the availability for access for the patient? And then making those decisions based on validated information and revisiting treatment along the journey with the patient. It's very important to think about health equity in patient-centered care, and an expanded model of shared decision-making that takes into account patient-centered care, social determinations of health, and health equity are important. So not only patients' values and preferences, but again, those social determinants of health, scientific evidence, the 3 of those being employed in that shared decision-making to drive optimal patient care, as well as health equity for all patients with hereditary angioedema. An HAE patient action plan is important, not only for patient understanding of when to treat if they have self-administered options available to them, but also for their caregivers, family members, and healthcare providers that they may encounter that are not as familiar. So this should list the signs and symptoms of HAE, how to administer the medication, what the medication is, why it's being used, any plans for travel and knowing where care may be in an area that somebody's traveling to, and when it is appropriate to self-administer and monitor, and when it may be appropriate to seek emergency care. These action plans are essential, and patients not only appreciate them, but those providers out there who encounter our HAE patients and aren't as familiar with the disease also appreciate them and are able to manage our patients more effectively thanks to these action plans. So that completes our HAE introduction and therapies. And now I am very excited to discuss a real-world case patient with Dr. Talreja. Dr. Talreja?
Thank you, Dr. O'Connor. That was a very, very good, thorough presentation.
Just
Thanks.
that.
And and I really, really think that yes, as exactly what you said, it's exciting and amazing time for allergist immunologists. I remember being in residency and doing allergy rotation, not having much options for HA, and here I come to fellowship, and there's so much to learn, and so much to devour about the new therapies coming up. So thank you for that great presentation. I'll go ahead and I think you'll advance the slides. So I'll
Absolutely.
present a good real world case that I saw recently or within the last year. So, I work out of Idaho, and of course, there is rural Idaho population that travels 6 to 7 hours to come see us. And here I am in a regular day, Tuesday, seeing my patients, and this patient walks in, 42-year-old, says that I have recurrent angioedema swelling. And I was like, oh, well, you know the word angioedema. And he said, yes, I have read about it, and it's angioedema. And I said, okay, let's talk more about it. So he tells me that, I have recurrent non-pitting, non-pruritic swelling episodes that I've seen PCP for. And I have these 8 to 9 episodes per year.
Mm,
I almost get one episode per month and have been having this since 10 years of age. He
mm,
says that the swelling usually initiates in my face and then sometimes it goes on to the neck, hands, or feet. And these episodes are super painful, really affect his quality of life. But he does not have any hives with it. On asking his triggers, he does say, you know what, I don't know how it comes, but minor trauma can cause it. He's a livestock farmer, so gets minor trauma, and that causes him to have swelling. But he also does report that emotional stress can cause it, and he also feels that it could be positive emotion, it could be a negative emotion, but that could cause him to have a swelling, and then he doesn't know what the trigger is really. He does also report to me that in the last 30 years or 30 or so years that he has had these symptoms, he develops sudden onset of laryngeal swelling that goes on and progresses over the next several hours, leading to breathing difficulty and stridor. And then he ends up being in the emergency room, and he has been hospitalized at least several times in the last 30 years for 2 to 4 days. To the point that now they have given him prednisone to just keep it and epinephrine just to keep it, to use it before he walks in the hospital, and they just intubate it if he needed to, and then he spends 2 to 4 days and then he's released
mm,
till he realized that, oh, this is an angioedema, and an allergist manages it. So he asks his PCP to, hey, I want to see an allergist. And of course, the closest allergist, and as important as I want to sound, is 5 to 6 hours from his place. So he comes to see me, and on more history, I ask him that, does this prednisone or the epinephrine or the antihistamines work for you? And he says, no, they have not made any difference, but nevertheless, I take all of them and then wait and watch.
mm.
Next, please, slide.
Yes.
On further, being thorough with the history, he does have history of hypertension, reflux disease, and allergic rhinitis. Being an allergist, we do want to ask him that he doesn't have any food or insect sting allergy, no history of asthma. When I saw him, his current medications were losartan for hypertension. And on just more history, I asked him that, was there any connection that you were ever given an ACE inhibitor within the last 6 months or so? And he said, I used to be on lisinopril, but they discontinued it last year because they thought that can cause angioedema. But for the last 1 year, I've been on losartan, and I still have the similar number of episodes. So he was taking losartan, his blood pressure was controlled, and he was doing well with that. And he didn't think that his frequency of attack has necessarily changed since the lisinopril was stopped and losartan started. He does use omeprazole as needed, and as I said, he does have prednisone steroid courses that he has it as a home supply by his PCP for these angioedema episodes to stop the swelling and not need hospital resources. He also has epinephrine auto-injector that he usually uses when he has a laryngeal swelling, and has used them, but it still ended up in the hospital. He only has had routine labs that have been done by the PCP, and they were all normal on my review. No liver, kidney, or renal dysfunction, or thyroid dysfunction. hospitalizations, as I already mentioned, that he has had multiple hospitalizations, but no surgical history, so he has no idea if surgery brings it on or not. But minor trauma does, as I already mentioned. Next slide, please. Um, he is a heavy smoker and smokes 11 to about 20 cigarettes daily and has been doing it for the past 20 years. He does not have any recreational drug use. He's a social drinker, two to three beers per occasion, but nothing, not a heavy drink alcohol inclination. He is a livestock farmer, as I mentioned, by occupation. He does raise cattle and sheep and a regular Idaho ranch farmer that we see here, and resides in rural Idaho, and has an indoor cat and dog that live inside. And then he doesn't have any allergies to any previous medications except the lisinopril that I mentioned was discontinued last year. And he is adopted. So his family history I couldn't obtain other than he's adopted, but he does live with his wife and he has a 10-year-old daughter that I did take more history and was not having any similar episodes at that point.
All right.
Next slide, please.
All right.
So yeah.
Ooh, a lot to unpack with this patient.
Yeah. So, I don't know Dr. O'Connor, but just practicing in rural Idaho, I would say that it was very interesting, and to just summarize this whole case for the audience to be able to realize where we are coming from is that a patient who has only available resources through primary care and ER physician, where HAE is not really known to these patients. And that's why this whole education that we are doing today, so we are aware of this disease and people can know how to manage it. But really this patient came in with lots of other concerns, right? Like he has long-term steroid use, he has trauma, he has emotional stress of positive and negative bringing it on. He knows something is going on. He looks it up online, finds the term angioedema. He's aware of his concern. And and of course, everything that going to the hospital is not fun. The quality of life is not fun. I mean, he is on ARB right now, right? And I don't know what you think about ARB, and Dr. O'Connor, I'd like you to tell me what you think about his being on ARB.
I think it's concerning. So a lot of things concern me about him. So 32 years before he sees somebody who specializes in what we think he might have, right? Hereditary angioedema, what we know he has. 32 years is a long time to suffer. He also has other co things that could be causing some of the symptoms. He's got GERD and he's a smoker. Are his laryngeal symptoms really angioedema? Is something else going on? Taking the meds that didn't work over and over again, the steroids and the side effects there, obviously would lead to much more mental health stress, right? Anxiety and side effects. But certainly the ARB is concerning to me because we know that ACE inhibitors are the most common cause, but ARBs can do it. Calcium channel blockers and beta blockers can also do it. So I know that you would probably talk about that with the PCP or whoever prescribed that. But again, that access to care, that's very important. 5 to 6 hours to come and see you, I think is also something we don't think about that often. I'm in Charlotte, which is, a big city. So patients just can find somebody on the corner. So it's lucky that you also had a patient who was his own advocate and looked up the symptoms, was able to figure it out. And this is why I love doing these educational programs, because this is a rare disease. So not every healthcare provider is going to know about it unless they're tuning in tonight, and for others that we do, right?
Yeah, I do say that, I feel special when I see these patients and, I tell them, I know your answer. I know you. I'll just need this blood test. I feel special, rewarded, and very good. But, the lack of care for 32 years, and I'm so very thankful that, I had the honor of coming here today to discuss and be an advocate for these patients who looked it up online themselves to figure it out, who they need to see. It's amazing. And yes, so I did. Did talk to the PCP.
Before we do that, we're going to do our polling question.
Okay.
You just set us up perfectly for what we'd like to ask the audience after we do the review of systems and vital signs.
Right. So I'll quickly go through for the sake of time. The review of systems and vital signs were normal. There was nothing indicative of any vital signs abnormality. Please go ahead.
Sure.
The physical exam was also normal. He didn't look in any distress. His skin didn't have any hives, any abnormal lesions, no lymphadenopathy. Lungs were clear to auscultation, and no edema on the extremities. Mm-hmm.
And, a lot of people don't realize that allergist immunologists do a full physical exam because they think we only do allergic rhinitis, right? But of course, we always do a full physical exam. And this is a great example of a patient who certainly needed one.
Yes, exactly.
So now the audience polling question, because you had mentioned the blood test that you got. So
Yes.
the question for the audience, and we will have a poll for you to answer, is what type of testing would you order for Dr. Talreja's patient who drove 5 to 6 hours to see her? C4, C1 inhibitor level and function, the Genang genetic test, allergy skin test. I mean, he is in livestock, around livestock a lot, or a CT scan of the neck and chest. So we're going to give you about 30 seconds to answer that. What is the type of diagnostic testing that you would order first for this patient? Just waiting for the results to come up. Giving it a few more seconds. There's the question again, if anyone needs to see it. All right, wonderful. Well, it seems that our audience is listening and paying attention because 86% said C4, C1 inhibitor level and function, and some think probably skin testing and CT may be warranted. So I'd like to talk about that with you. What did you do, Dr. Talreja, and what did you find?
It was a very pleasure to see this patient. Of course, I don't do blood draws in the office, so I think I agree with the 86% people listening here that we will go ahead and send a C4, serum C4 level, C1 INH, and INH function. But I would say that since he came 5 to 6 hours away, he had not been on antihistamines. I do agree with the allergy skin testing to rule out his allergic etiology of his allergic rhinitis to the indoor cat and dog that he has. He's a smoker, so I just wanted to make sure there was not associated allergic asthma that's complicating his picture in future. So I did do a thorough workup, and I did do allergy skin testing on this patient. I did not do the CT scan of the neck or chest, but I do want to just mention a word that, I think for the audience that chose that question, I mean, yes, and if it was as, some kind of obstruction, especially in a patient who is a smoker and a heavy smoker, you would like to know if there is a malignancy involved or a nodule out there that is concerning, that can cause acquired angioedema or some kind of a workup that you wanted to do down the line for him. But and I just wanted to have a quick word about Genang test, and it's basically a HAE focused gene panel that it's a next generation gene sequencing test that looks at the variants of all the variants that Dr. O'Connor mentioned in normal C1 HAE. So yeah, just something that I wanted to bring it out there so you guys are familiar that test exists. I did not order that test, of course, and went on to do the C1 INH and function and number.
And the C4, right?
Yeah.
Right. And I think it's important to know about the Genang testing because, again, it's something we didn't have available always, right? For when I first started taking care of the patients. I'm just a little bit older than you, so we didn't have genetic tests. We didn't have all these therapies. But yes, so in the interest of being a good steward for access to genetic testing and cost, if the C4, C1 inhibitor function, which is the first line test we would want to do, were positive, we wouldn't need to go down that road necessarily, right? But I agree with what you said about the imaging and the smoker, that's heavy of a smoker. That might be something to discuss with the primary care physician as well, right? So great. So these are your results from your patient, right?
Correct. Yes.
Okay.
So, as you can see, I mean, it was just a very straightforward, rewarding case, but not so much for the patient. Suffering 32 years is not fun with the quality of life, as Dr. O'Connor had mentioned in her lecture. But so the lab results did come back, and he had a C4 protein level, which was low. C1 INH function was low, as well as was the number. So therefore, we diagnosed him with type 1 HAE. Sorry.
I'm just kidding. We know what it is, right? But we're supposed to poll the audience. So let's poll them. We want them to be actively participating. So
Yes.
based on the patient's lab results and what we've learned from the slides I presented, as well as Dr. Talracia's presentation of the case, what is your diagnosis, audience? HAE type 1, HAE type 2, HAE with normal C1 inhibitor, allergic or idiopathic angioedema, or ACE inhibitor-induced angioedema? I don't think there's a lot of suspense here. But while we're waiting for the poll, I'm going to be interested when we get to the next discussion about your patient's response when you gave him the diagnosis and what kind of relief and how his emotions. I'd be very interested in that.
I can't wait to
Our
share that.
results show that yes, we have almost 100% saying HAE type 1 or 2, and also having some ACE inhibitor-induced angioedema, which I agree with that. So let's go on to our discussion. If I can work the slides, there we go. So tell me what you diagnosed the patient with and what did he say?
Oh, that was the most amazing feeling. You're looking at those tests and being able to help somebody up at 32 years. So yes, he did have low C4, C1 INH and the function. So we did diagnose him with HAE type 1. And then, I did a televisit with him as a share. And then, as we always want to talk to them about on-demand therapy, the alternatives, the long-term prophylaxis, and have a shared decision-making of how we want to approach him and the alternatives. And I also did talk to him about that I did call his PCP and of course talk to him about the ARB, to change the ARB to another antihypertensive, just discussing about the case reports that we've seen of angioedema with ARBs as well. I taught him some lifestyle modifications at his work and stuff. But the most important thing is that I talked to him about therapy. I talked to him about short-term therapy, rescue treatment, which I put him on icatibant as a rescue treatment, and I made sure that he had at least 2 doses to be able to use for acute attacks. And I started him on lanadelumab. I chose that based on our decision making for him.
And here is the audience polling question to address exactly what you're saying, which is perfect timing. So what changes to the patient's current treatment plan would you recommend? And as Dr. Talracia has already reviewed some of this, but recommending prophylaxis for HAE, alternative therapy for acute HAE attacks, no steroids, antihistamines, or epinephrine, alternative medication for hypertension, A, B, C, A and B, or all the above. And I think that Dr. Talracia has summarized this nicely, that it's really all of the above. And while we're waiting for the audience's answers, I think it's important to remind the audience that normal complement levels would be seen in allergic, idiopathic, or ACE-induced angioedema, but certainly ACE inhibitors are contraindicated in HAE. But that's a distinction that I think is important to mention. And that these labs are something that any specialty can order, a C4, a C1 inhibitor. It doesn't have to be an immunologist ordering that. And I think that's also important. So yes, the majority of people agree with us, Dr. Talracia, all of the above. So continue your discussion about what you did.
They're listening to me summarizing ahead of the conversation, but thank you guys. I did do all of those, and that was great answering in the poll that we do recommend prophylaxis as well as long-term and short-term prophylaxis to the patient. And I would say that I did have them change the ARB just for all practical purposes to keep it easy for me and him to manage his HAE attacks. And then we did do short-term prophylaxis with icatibant, and we did long-term prophylaxis with lanadelumab. And I saw him back, a couple months back.
And
am I supposed to share the secret, or there's another polling question that I have?
There's not another polling question.
Okay.
But
so
we have 1 minute.
So 90%.
90%?
Right. And it was amazing. So he was using lanadelumab every 2 weeks. and it was, a 6-month more follow-up on that. And we were talking about reducing even further if he continues to stay attack-free like that. So super amazing. No hospitalization, no laryngeal swelling in the last 6 months. And so great, very rewarding case. And I'm so happy to be able to present and share his history with you guys.
Thank you very much. And we are going to now just talk about some key points. Early diagnosis is essential to ensure appropriate treatment and improve disease outcomes for patients with HAE. First-line diagnostic testing, C4, C1 inhibitor, level and function. If normal, but HAE is still suspected, then consider genetic testing. Treatment should target reduction of disease impact on patients and caregivers with on-demand therapy for all patients and prophylaxis as needed. And the HAE treatment landscape continues to evolve, increasing options for on-demand as well as prophylaxis coming. And again, very exciting. But HAE management should be personalized based on attack frequency, severity, and patient preferences. We are at the top of the hour, and unfortunately, I know we cannot take any questions from the audience, but I would love to thank my co-presenter, Dr. Talreja. You did an excellent job, and thank you so much for sharing this patient. It's great to have a success story to discuss, and I hope that the key points are helpful for our audience. Thank you to Integrity very much for having us here tonight.
Thank you, Dr. O'Connor and Integrity. It was a pleasure being here. Thank you.
Thank you very much. Good night, all.
Good night.